Let's get right into it, because today we're focusing on a topic that's been generating some seriously alarming headlines lately: the emergence of a superbug yeast known as Candida auris. Look, if you've been following the news, you might be feeling a bit of panic about this pathogen. Totally understandable. But our goal today is to strip away the sensationalism and just look at the actionable scientific facts. We're going to break down the data to see what this fungus actually is, who is genuinely at risk, and the specific strategies the medical community is rolling out to detect and contain it.
To understand why public health officials are on such high alert, we really have to anchor ourselves on this number: 30 to 60%. That is the estimated mortality rate for patients who develop an invasive bloodstream infection from this pathogen. It's a severe number, right? And it absolutely establishes why this demands our immediate attention. But, and this is a huge but, we also need the context here. That mortality rate specifically applies to highly vulnerable, immunocompromised patients who are already fighting complex medical battles. We need to respect the threat, for sure, but we also need to understand it precisely.
Here is the roadmap for today. 1. The Candida auris threat. 2. The 2026 case surge. 3. Who is actually at risk. 4. Accurate detection. And 5. Stopping the spread.
Section 1. The Candida auris threat.
So, Candida auris is a type of yeast. It was actually first identified pretty recently, back in 2009, when researchers isolated it from a patient's external ear canal in Japan. Since then, it has exploded into a major global healthcare-associated superbug. Now, you might also see it referred to as Candida auris. That's because in 2024, it got reclassified based on its genomic taxonomy. But, a lot of public health authorities are still using the more familiar name Candida auris. What makes this yeast so incredibly tricky is really a one-two punch. It's highly resistant to standard antifungal treatments, and it has this crazy ability to just persist for weeks on environmental surfaces. We're talking bed rails, doorknobs, medical equipment, you name it.
And this brilliantly illustrates why it's officially classified as an urgent antimicrobial resistance threat. Normally, we have three main classes of antifungal medicines to treat humans: azoles, echinocandins, and polyeins. But it's really important to keep in mind that different strains have totally different levels of resistance. Most strains we're seeing in the US are actually still susceptible to echinocandins, which is great. The scary part, though, is the emergence of pan-resistant strains that can basically shrug off all three of those main classes. The good news? To combat this, the medical community isn't just sitting still. They are already deploying entirely new classes of antifungal drugs designed specifically to fight these highly resistant infections.
Section 2. The 2026 case surge.
The epidemiological data we're seeing in recent reports is pretty staggering. According to the Beacon Disease Event Feed, by early 2026, we crossed over 7,000 reported cases, spread across 27 different U.S. states. That's a massive 55% jump just from the levels we saw in 2024. The geographic expansion is basically relentless right now, driven heavily by major hotspots, especially the really sharp rise in cases we've seen sweeping across New York in 2025 and 2026. To put that into perspective, back in 2015, there were literally 0 reported cases in the United States. 0. Today, it's established an endemic footprint in more than half the country.
Now, what's really interesting about this slide is the sheer velocity of the increase when you zoom in on localized data. Take a look at this chart from the Philadelphia Department of Public Health. In 2024, Philly saw a 129% jump in cases. In 2025, it jumped another 115%. And notice those two colors on the bars? The orange represents screening cases. That's people who are carrying the fungus but have no symptoms, while the blue represents active clinical infections. So this surge isn't just happening because we're testing more. Actual clinical illnesses themselves jumped 117% in 2024.
And we're seeing a very similar story play out in the Midwest. The Missouri Department of Health and Senior Services reported 829 total cases since 2023, and over 50% of those affected patients who are 65 or older. It just goes to show, this isn't an isolated coastal problem. It's a widespread, multi-regional issue infiltrating everything, from acute care hospitals to long-term skilled nursing facilities.
Section 3. Who is actually at risk?
Listen, this right here is the absolute most important takeaway for anyone watching who might be feeling a bit anxious. Yeasts are opportunists. They need an opening. The high-risk group consists almost entirely of patients with severe underlying medical conditions who are hooked up to invasive medical devices. We're talking breathing tubes, mechanical ventilators, feeding tubes, central venous catheters, things that provide a direct physical highway for the fungus to bypass the skin and enter the body.
On the flip side, if you are a healthy individual without those invasive devices, your risk of infection is incredibly low. Simply staying healthy keeps your body's defenses up and prevents opportunistic organisms like yeasts from ever becoming pathogens. Even the healthcare workers treating these patients or family members living in the same house are considered very low risk.
But we do have to make a really major distinction between being infected and being colonized. A clinical infection means the yeast has actually entered the bloodstream, wounds, or ears, and it's causing active illness. Colonization, on the other hand, just means the person is carrying the fungus on their skin, usually in warm places like the armpits or groin, without showing a single symptom. They aren't sick, and honestly, they shouldn't even be treated with antifungals. The catch? A colonized patient can invisibly shed the fungus onto surrounding surfaces. Plus, current medical guidance considers these patients to be colonized for life. This invisible shedding is exactly how it spreads like wildfire to other highly vulnerable patients if strict protocols aren't locked in.
Section 4. Accurate detection and diagnosis.
For a really long time, the medical community was kind of fighting in the dark. Candida auris is notoriously tough to distinguish from other, way less harmful Candida species. If a lab uses traditional, old-school yeast identification methods, it frequently gets misidentified, usually as something called Candida humuloni. That misidentification is super dangerous because it delays life-saving infection control measures and the right treatments, which just allows the superbug to spread completely unchecked through a facility.
But here's where technology is totally turning the tide. The rollout of newer identification methods, specifically PCR testing and maldi-tof mass spectrometry, has been a complete game changer. Thanks to these tools, the rate of misidentification has decreased significantly. By relying on this advanced tech instead of traditional lab cultures, public health officials can instantly, accurately flag the pathogen and trigger those immediate containment protocols. It's the gold standard.
Section 5. Stopping the spread.
So the crucial part is that healthcare workers absolutely have to adhere rigorously to these essential infection control protocols. Get this, transmission has been documented after an exposure period of just 4 hours. 4 hours! Because of that, facilities have to implement strict hand hygiene, and surprisingly, good old alcohol-based hand sanitizer is highly effective against it. Patients are immediately placed on contact precautions or enhanced barrier precautions if they're in a skilled nursing facility. And crucially, if a high-risk patient is just awaiting test results, they are put into preemptive isolation so they don't accidentally expose an entire hospital ward while the lab processes their swab.
Now, what about the room itself? Well, standard hospital cleaning products, they simply do not work against Candida auris. Because this fungus can hang out for weeks or even months on medical equipment, facilities absolutely must use specific EPA-registered heavy hitters. They need products from EPA List P, which have specific, proven kill claims against C. auris. If they can't get those, they have to use List K disinfectants, which are literally strong enough to kill C. difficile spores. Diligent terminal cleaning with these specific chemicals is absolutely non-negotiable.
As we wrap up this explainer, I want to leave you with a larger, systemic question that researchers are seriously looking into right now. We know these scary, pan-resistant strains are emerging, but why? Well, one theory points right at the widespread use of agricultural antifungal azoles. These chemicals are sprayed globally to control plant diseases, but they stick around in soil and water for months, putting massive selective pressure on fungi out in the environment. So could our own agricultural practices be the hidden driver, literally training this superbug to defeat our best human medicines? It's a fascinating look at how deeply interconnected global antimicrobial stewardship really is. Thanks for joining me for this breakdown, and remember, keep asking the right questions.